morning. It's a real pleasure to be here with you this morning. Angela, is my voice loud enough in the mic? How's that? Can you people hear me? Excellent. I have a bit of a cold, so excuse me if I take a drink every so often. My voice is dry. Thank you for that nice introduction. As Bob said, my name is Cathy. I'm a clinical psychologist and I'm associate professor at King's, and I'm the director of the King's Center for Deaf Education Accessibility Forum, which we call CDEAF. It's a real pleasure to be here today. Now, I just want to advance this slide. Perfect. When I was asked to do this talk, I did a little bit of research first about this group because I didn't really know too much about it. And it wasn't too hard to find some pretty impressive pictures on the web. Look at these people. It was pretty easy to find this impressive group of people on the web. And I was really impressed to learn that this group, the senior alumni group, is Western's award-winning program, the largest, the longest running lecture series in Canada. That's amazing. So these kinds of talks that you people come to apparently have been going on for about 40 years. So give yourself a hand. That's pretty amazing what you've done. Well, so when I was thinking about it then, it became pretty clear to me that I was going to be here talking to a room full of greatness. Right? And then I thought a little bit more and I thought, you know what? I'm going to be here talking to a room that's probably full of wisdom. And then I got a little bit more nervous because I thought, I'm going to be here talking to a room of people that have way more experience than I do. And I'm probably also going to be here talking to a room full of incredible mentors that have been devoting much time to bringing scholars and academics and clinicians on board. So all this was a little bit overwhelming to me. Then I thought, but you know what? Probably I'm going to be talking to a room full of people who go to the bathroom a lot. Am I right? So that made it seem a little bit easier for me to come. Now, you know, as we get older, as we age, we all expect those kinds of changes, right? We expect to have to go to the bathroom a bit more often, a bit more frequently. We expect to have some problems with our mobility, that maybe it's going to be harder for us to exercise. Maybe our joints aren't going to do exactly what we ask them to do. We expect that it might get a bit harder to see things. How many of you, hold the paper way out here or use a magnifying glass to see? That's kind of expected. And we expect that as we get older, it's going to get a bit harder to hear. Maybe with hearing aids, or as this guy's doing on the slide, needing to have his hand up to get the sound a bit closer to him. So those changes seem inevitable somewhat as we get older. Would you agree? Would you agree? And those changes are very expected. Maybe we don't like them, but they're shared by a lot of us. And we would expect to have to deal with some of those issues as we get older. What I've learned in my life, though, it's really the unexpected things that change our lives forever. Not the expected, but the unexpected things that change our life forever. So take me, for example. So I grew up in London with two parents, one brother, many privileges, and a pretty typical middle-class family. I had great family, good school, awesome teachers, many opportunities, lots of friendships, and many privileges. I was very fortunate. My parents always taught my brother and I to be thankful for what we had, and I think I was. I was thankful for what we had, but looking back now, I sometimes wonder, did I even really consider what I had, or did I even think about how it could have possibly been different? I didn't. Anyway, that was me. I grew up happy, pretty content with the world. I graduated from Western. I came here for my first degree with an undergrad in nursing. Graduated that year, traveled Canada. I was on top of the world, Came back that fall to a job in the neonatal intensive care unit at St. Joseph's Hospital, and I loved it. I was on top of my game. I loved it. I decided I wanted more, so I applied for medicine. My applications were in, and I was ready to go. So I was one of those frogs there, pretty content with life, pretty full of myself, pretty sure I had everything in the way I needed it to be, and I was ready to get out there and make my mark. Well, as fate would have it for me, that's when the storms hit. At the age of 23, I was admitted to University Hospital on New Year's Eve with a severe encephalitis, an infection of the lining of my brains. I was very sick, and my memories are very sketchy around that time period. I survived that encephalitis, but I remained seriously ill in the hospital for months. And the neurologists at that time were at a loss to understand what was going on, why I was so sick, and what was happening to me. Despite extensive testing for cancer, for MS, for lupus, for other serious neurological conditions. Eventually, I wore them out, and I was sent to the Mayo Clinic in New York State. But despite a lot of testing there, they too couldn't come up with a diagnosis about what was happening. I was having significant neurological symptoms at that time, including multiple transient ischemic attacks or small strokes, a blinding pain in my head, loss of sensation and function in different parts of my body, and feeling generally really, really bad, really nauseated, really sick, feeling quite ill. Eventually, Dr. Rick McLaughlin, who was the first neurologist who saw me that fateful New Year's Eve, and is still a neurologist at University Hospital, and I might add, has become a very, very close, lifelong family friend now, helped to diagnose my disease at the time by some of the contacts he had worldwide, diagnosed me as having a very, very rare autoimmune disorder called, at that time, the Red M syndrome. Now, at the time, I was the 14th person in the world identified in the literature with that disease. Now, I'll give you a hint. If you want to become famous, don't become famous to neurologists. That's not the way to do it, not the way to do it. At that time, it was called the Red M, R-E-D-M, so R for retinopathy affecting my eyes, E for encephalopathy affecting my brain, D for deafness, and M for microangiopathy. It was later named Susak's disorder, after a neurologist in California who identified more patients with the same disorder. Well, my difficulties with my rare disorder continued for a number of years. I was treated with high doses of chemotherapy drugs and high doses of prednisone steroids. Sometimes, you know what, I wasn't sure which was worse, the disease or the side effects of the treatments. And my life, it basically stopped. As I dealt with the flares of the disease, I dealt with the loss of a career, I dealt with the loss of my dreams, the loss of my hopes, the loss of my aspirations, the loss of many friends, and the loss of what seemed probably the hardest and integral part of myself. And I remember that night really well. The morning. I was in the step-down intensive care unit at the time on the 7th floor neurology at University Hospital, and there you had one-to-one nursing. And every morning, my mom would call the unit to see how my night had been. Well, that morning, the nurse answered the phone, and she handed it to me. I said, hello, didn't hear anything, so hung up. Nurse handed the phone to me again, must have rung again. I took it, and I said, hello, didn't hear anything, handed it back, hung up. The third time, the nurse answered the phone and talked with my mother. And what we realized was that I couldn't hear. That essentially, I had suffered a stroke in the night, which had left me deaf. So testing showed I had a severe sensorineural hearing loss in my right ear and a profound loss in my left ear. Can you imagine? I went to bed hearing, and I woke up deaf. Those storms continued for me for a number of years. They left me literally broken, left me literally in a shambles. I spent many weeks and many months at a time in the hospital as I would become a bit stable, and yet the disorder would flare again, and then I would be readmitted. And it seemed to me that everything I knew had changed. My friends were getting married, my friends were having babies, my friends were going off on trips, my friends were doing graduate degrees, and what did I do? I stayed at home or in the hospital, sick with Tay-Sachs disorder. With the fear of losing more eyesight, I had already lost a bit of my vision at that point, and I was already deaf. My sense of self, my sense of identity, my sense of who I was, my hopes, my dreams, what I was going to do in the world, all were different. All changed. I was dating a guy named Scott at the time when I first became ill that New Year's Eve. But how do you continue a relationship with someone, with a boyfriend, when you can no longer hear him in the same way that you could, or hearing him took so much effort, or even perhaps more importantly, our realities were somehow so different now? And that's how I felt for many years. Confused, lost, unsure, unclear, perplexed, disorientated, bewildered. Well, I'm leaving many, many, many parts of my story out this morning, but over a number of years, and with a great deal of support from my neurologist, Dr. McLaughlin, from my parents, from my family, from my friends, and from my faith, I and Tay-Sachs disorder carried on. We carried on together. I went to Gallaudet University in Washington when I was a bit more stable. Gallaudet is the world's first and only liberal arts university that is for the deaf people, where the language of instruction is in sign language and the majority of faculty are deaf. I had my first introductions there to a world where people were born deaf. And then eventually I ended up coming back, getting things sort of in place, and I did my PhD in clinical psychology. And you know what? 10 years later, I married Scott. And I think he's here today somewhere. Where are you, Scott? There he is. Oops. Well, from my experiences then, and in those unexpected ways that my life changed, I became particularly interested, both professionally and personally, in a world that wasn't based on sound. I became interested and I was exposed to different perspectives on life. I became interested in sign language, world sign language, such as American Sign Language, which you saw Angela this morning. I became interested in the idea of deaf culture, where these different perspectives and these languages are the norms. And then I became especially interested, because of my area of expertise, on how all this intertwined with mental health. And so these are some of the things I want to share with you today during our time this morning. It's been many years now since I've become deaf. And I've been very privileged, honored, very honored to work with many deaf colleagues, have many deaf friends, have many deaf patients, and from them, I've learned a lot, and I'm eternally grateful. And for that, I just want to share with you a little bit of what I've learned and what I've experienced. There's different ways of thinking about sound. These ways of thinking have evolved into different perspectives in life. Now, the medical perspective is one we're pretty much all familiar with. If I break my arm and go to the hospital, it's broken, I want it fixed. And that's what the medical perspective does. It makes things better. What's broken becomes fixed. Efforts are made often to right a wrong, make something that's not working as well work better, improve upon what can be improved upon. Now, in terms of hearing loss, then, the medical perspective tends to really think about your ear, the part that's not working, or the cochlea, the part that's not working so great, the part that's broken and should be fixed, maybe with a cochlear implant, or maybe with a hearing aid. So deafness from the medical perspective, then, is viewed as a deficit. It's a wrong to be made right. But the other perspective of deafness is one from a cultural perspective. There's people who have been born deaf, or who have typically been deafened at a very young age, who consider deafness to be their birthright. They consider it to be their heritage. They consider themselves proud to be deaf. They have a culture complete with a sign language, traditions, and mores. And you know, being deaf is not viewed as being a deficit. It's viewed as being a difference. And it's viewed as a difference that should be and is celebrated. It's a really unique way of being in the world. And it's a different way of being in the world than someone who is in a world based on sound. It's a paradigm that doesn't depend on sound and depends on all sorts of other facets and other factors to make it a complete way of being. Now, many people are aware of American Sign Language, or ASL, but they think of it as a simplified code for English. In actual fact, ASL, like all of the other world sign languages, is a very complete, complex visual language. And it's based on signs, it's based on facial expressions, and it's based on posture. It has its own grammar, has its own syntax, it has its own complete set of linguistic rules. Now, ASL is the first and the preferred language of many deaf people in both Canada and the USA. It's also the predominant sign language of deaf communities used in Francophone Canada, and it's called LSQ, primarily in Quebec. Now, deaf culture, that term describes those social beliefs, the rules of behavior, those rich values, those traditions, the storytelling, and the language that guide this group of individuals. Now, these deaf people, this group is a minority within the larger hearing majority. And as such, like many minorities, they've been exposed to considerable discrimination and considerable oppression. As a deaf clinician and a deaf academic here at Western University, I can detail the barriers I still face on a daily basis. But for the majority of deaf people, culturally deaf people, these barriers have existed since a very, very young age. And this has sadly often influenced their lives in very, very negative ways. Well, how many people am I talking about here? Well, statistics are really quite hard to obtain, accurate statistics. And as a scientist, I want accurate statistics. But consider that often Stats Canada recruits their data through calling homes and getting information. Well, that excludes people like me who don't use and can't use a voice telephone. So stats can be hard to obtain and to really have reliable and valid numbers. CAD, or the Canadian Association of the Deaf, estimates that here in Canada we have about 350,000 culturally deaf Canadians and another 3.15 million hard of hearing Canadians. Not that small of a number. Now, the Canadian Mental Health Association, or CMHA here in Canada, they estimate that in any given year, 1 out of 5 of us, 1 out of 5 Canadians, and I think that number is going up, will personally experience a mental health illness or problem. 1 out of 5, so think of this room, that's quite a number of us. Well, what about deaf people? Well, we need better research. We don't really know how many deaf people have these mental health disorders. We need better research in Canada, but international studies suggest, and there's no reason to believe that we're not different, is that deaf individuals experience mental health concerns at a much higher rate than hearing people do. Now, when I say mental health, I just want to remind you that I'm referring to all those really complex intersection of factors involved in the biology of life, involved in the psychology of life, and involved in the social factors that affect all of us. It's that intersection of all those layers and layers of factors that end up being our mental health, that ends up being our well-being. So here's kind of an easy way to think of it. We all balance our own unique positives and negative stressors in our life, right? Much of our lives is like a teeter-totter. And mental well-being or mental health is intricately involved in that very, very fine balance. So the question that becomes probably for all of us in this room, and especially for deaf people, what tips that balance? What tips that balance towards negative mental health or negative well-being? Well, all of the following factors affect each and every one of us in this room and bring us to where we are at this point in our lives. Genetics, biology, environment, experience, family, social factors, life events, and culture. But I want to suggest to you people that it's the last two that are extremely, extremely influential in the lives of deaf people. Inequities, simple and complex unfairness in life, and language. Delays in being exposed to language, delays in being able to develop language during that critically important developmental period when our brain is so open as a young child to absorbing language. If we miss that critical period of development afterwards, it's almost impossible to develop first language fluency. So inequities in life and language become very influential for deaf people. Now, I've devoted most of my professional life, and a good deal of my personal life, it feels like, to better understanding then what are the facts about mental health and deaf people. Because deaf people are not the same as hearing people. Their paradigm, their understanding, their worldview, their experience is much different. So how do they experience mental health? Well, I can tell you this. The mental health system, probably to most of you in this room, seems pretty complex and difficult to navigate through. It seems pretty hard sometimes to understand where you're supposed to go, when, how you do it, who you're supposed to talk to. It can be pretty confusing to hearing folks. But if it's confusing to you who can hear, let me tell you how insurmountable and inaccessible it is to deaf people due to cultural and due to linguistic barriers. Think about it. How do you access your family doctor? The family doctor is often the frontline person in the mental health care system. How do you access them if you can't pick up a phone and easily call to make an appointment? And even if you do get past that hurdle and you make an appointment, when you arrive at the family doctor's office, how do you share your innermost fears and struggles and thoughts, what might be happening in our souls, if you don't share the same language as the family doctor? Professional interpreters like Angela, right here, are few and far between and have a significant waiting list. Now, you know what? Sometimes family doctors, they try their best and they'll write their interview questions out to deaf people. Seems like a good idea, but it's not. So for many deaf people, literacy is a huge, literacy in English, and remember that's not their first language, is a huge challenge. For many, literacy rates remain around the grade 4 level. Now, that's nothing to do with their intelligence or their cognition or their potential or ability to learn, but it's everything to do with how hard it is to learn to read and write in a phonics-based language without ever hearing a word or a phoneme. It's a huge challenge for the educators and for the deaf people. So writing back and forth isn't a good substitute for clear, open communication, especially when we're talking about mental health. Navigating through the system can be insurmountable. There can be a lack of community support. Overwhelmingly, deaf people are underemployed, so there's limited financial support. And did you know that 90% of deaf people have hearing parents? And of that group of deaf people who have hearing parents who learn sign language as their first language, the vast majority of them never have a shared language with their parents. The parents continue to speak English, the child grows up using ASL, and they never meet. Therefore, we often see strained and distant extended family support. Now, in terms of many of the major mental health disorders, such as depression, such as anxiety, ADHD, post-traumatic stress disorders, schizophrenia, bipolar, learning disorders, eating disorders, psychotic disorders, all those up on the screen, we know they affect both hearing and deaf people. Both will and do experience them. However, research shows us that deaf people are much more likely to experience a mental health problem than a hearing person. Now, it's really important for clinicians as well as for deaf people themselves to understand better why. Why is that? Well, we know that the prevalence or the rate of how often these mental health disorders do occur is not only higher, we know that, but also what we've learned through research and through clinical work is that the actual presentation of clinical symptoms in deaf people is different than it is in hearing people within the same disorder. So the pieces of the puzzle between deaf people and hearing people in mental health is very different. Now, if this is not well understood by the general healthcare system, how will deaf people ever receive appropriate and effective mental health care? Or if the deaf people themselves don't understand this, how will they ever access appropriate and effective mental health care? Let me give you two very brief examples. Okay, I want you to think about a hearing child who's been diagnosed with autism spectrum disorder. Autism spectrum disorder. Now, the way we diagnose autism spectrum disorder in a hearing child is based, and I'm simplifying things, but it's based on how the child uses language and how they socialize in qualitatively different ways than what a typically developing hearing child would. There are qualitative and significant differences in language and socialization. And then they get a diagnosis of autism spectrum disorder, and the earlier the identification, by far the better the outcome, because then we could get intensive mental health care treatments and strategies in place. But consider if that child's a deaf child. So that child who's deaf may not have been exposed to an effective or accessible or an appropriate language during that critical period of brain development. And if they're not exposed to that, they're going to have delays in their language. They're going to have impoverishments in their language. And over again, I see deaf children who have exceeded that critical window of language development, never able to develop language effectively again. Even this happens with cochlear implants and with hearing aids, because sometimes there's a mismatch between what the best strategy is for the child and the language component that's given to them. Now, we know that language directly impacts the world and how a child interacts with that world and how the child interacts with everybody around them. So again, they're going to be acting qualitatively different than someone who was exposed to language at an appropriate time. So therefore, it would be very easy for an uninformed clinician to look at the deaf child and diagnose them as having autism spectrum disorder based on their peculiar language and socialization behaviors, when in fact, that's because of language deprivation, not autism spectrum disorder. Or alternatively, what if the hearing uninformed clinician looks at the deaf child and says, oh, that's just how deaf kids act. So all deaf kids act a little bit weird that way because language isn't easy for them and they act a little bit socially awkward with people. That's just being deaf. What if, in fact, that deaf child has autism spectrum disorder and that diagnosis then is completely missed? So when you think of that scenario, think about the impact upon treatment. What happens? I want you to consider, oops. Oh, what did I do here? I want you to consider another example. Think about When I did my residency in the hospital, there was a very disheveled deaf man who was brought to the hospital by police. He had been out in the community on a bridge and was upset and waving his arms and causing all sorts of issues. And the police came and they tried to restrain him. And how did they restrain him? With handcuffs. So if you handcuff somebody who's deaf, whose language is American Sign Language, you have effectively removed their language. It would be like stapling your lips shut and then taking you to the hospital. And so what did the deaf person do? He was terrified, and he became agitated, and he became violent. When he arrived in the ER, the uninformed clinician at the time asked the man through writing notes if he was hearing voices. Now consider this. This is a deaf man with no frame of reference for voices or hearing voices. And consider him, he's in the throes of this distress. He shook his head no. Looked at them and shook his head no. So the clinician decided, oh, the guy's just really stressed, send him home and things will kind of sort themselves out. Sent him home, but the man tried to kill himself. And he was brought back to hospital, thankfully was admitted, and a very in-depth, accessible, culturally, linguistically appropriate assessment revealed a very, very elaborate system of hallucinations and delusions, as well as many positive and negative symptoms of schizophrenia. So when you think of those missed diagnoses then, and the impact on treatment, and how difficult we are making it for somebody who's deaf trying to access mental health care. Now, the reality of being deaf in a hearing world often involves some of the following issues. I briefly mentioned, and each of these could be an entire course that I teach, the importance of early exposure to accessible language right from birth on. That typically doesn't happen with deaf kids, and they miss that period of language development, which I've told you we don't get back. We don't get a second chance. Our brains go on and do other things, so although we're sponges for a while, give me language, I want to learn language, any language, I don't care what the language is, the brain says. After a certain point, the brain shuts it down and says no more. After that point, it's really hard to acquire any kind of first language fluency. Think about the impact on attachment relationships with hearing parents who may not understand how to interact with a child whose reality is different than their own. Think of the differences in how learning happens. A lot of you grew up with incidental, like I did when I could hear. Incidental learning, you overhear your parents discussing something, and then you absorb it and you learn it. Incidental learning doesn't happen to deaf people unless it's right in front of us, right in front of our eyes, or we're directed to it, because I can't hear what's happening over there. I don't know what's happening behind me. I know what's happening in front of me. So incidental learning takes on a whole different face in deaf people. Understanding, forming, maintaining, developing relationships. The lack of employment opportunities, significant and ongoing barriers that they experience every day of their life, trying to navigate through a world that's based and set up for people who can hear. Lack of knowledge and access to physical and mental health care. The vast majority of deaf people give up. They don't go to the doctor because it's too hard. It's just too difficult. They don't go to the hospital unless they're very, very, very sick, and again, they have no other choice, because how can they understand what's happening? And finally, those differences in worldviews that I already talked about a little bit earlier. So all of those issues regarding the reality of being deaf in a hearing world come together. And I think we see these unique mental health issues on top of these major mental health disorders that all of us are vulnerable to. And we see depression, anxiety, frustration, anger, and hopelessness all mixed up and rolled in to these mental health disorders as experienced. All of this can result in very unique clinical presentations of mental health. So what have we learned? Well, what have we learned through all of this? Well, best practice facts include the following. Being deaf does not cause a mental health disorder. Being deaf does not cause mental health disorders. But being deaf can be a risk factor and may be associated with significant mental health disorders. And that's a very, very important fact that we need to pay attention to from a systemic perspective, as well as a parent perspective and a societal perspective. Overall, there does appear to be an increased rate of mental health disorders in the deaf population. And we see this beginning in childhood, going right up to adult. Did you know that the majority of mental health disorders that we experience as adults somehow surface during childhood? We may not have been able to identify it as childhood, but there was definitely risk factors or symptoms of those mental health disorders before the age 14. So we should be able to identify them much better in hearing people as well as in deaf people. We know that clinicians need, both hearing and deaf clinicians, need to have specialized training and experience. Bob mentioned that I was the first deaf clinical psychologist in Canada, which is great, but it's also crazy because look how big Canada is and there's still only 2 of us. That's nuts. So we need to be giving deaf people more opportunities, more training, and hearing people more opportunities and more training to become specialized in this particular area. Treatment, assessment and treatment, diagnosis has to be culturally, and that goes back to those worldviews, how we understand the world around us, and linguistically accessible. If not, we might as well not be offering treatment because it has to be culturally and linguistically accessible before we see any gains or any benefits. Deaf individuals themselves, their families, and the deaf community. Did you know we have a sizable deaf community here? Because one of our 3 provincial schools for the deaf is located here in London, Robarts School for the Deaf. And in the past, deaf kids would go there, graduate, tend to stay in London, have their families. So we have a fairly invisible but sizable deaf community right here in London. These communities need to be better educated about their own mental health. They need to understand what's happening to them when they get in times of distress and what's happening to their family members, and even of more importance, how to access help. How to access help and how to access support. The hearing mental health care system must be made accessible. These barriers just can't stay in place. Lives are being lost because of it. We know that interpreters, who often act as the bridge between the 2 worlds, must have training in mental health, because the interpreter who goes to the bank to interpret for the bank, mortgage, doesn't have the same set of skills necessarily that the interpreter who is doing a clinical interview with someone who is psychotic and really experiencing delusions and hallucinations. Those are different sets of skills, and interpreters must have specialized training in mental health. And skilled mental health interpreters need to be thought of as a necessary and a critical part of the healthcare team, not just someone cute who stands up on stage and does a little bit of signing. They have to be considered a very important part of the healthcare team in order to make these treatments accessible. Now, I think it was about 3 years ago, we established a center at King's called the King's Center for Deaf Education and Accessibility Forum, and the summary is at CDEAF. Now at CDEAF, we're engaged in significant research. We're looking at different mental health disorders and how they present differently. We're looking at tools that we use to assess mental health disorders with hearing people, and we're translating them into American Sign Language, ensuring, and it's a very, very rigorous translation process, to ensure that they remain reliable, they remain valid, that they're assessing what they were designed to assess. So we're involved in those translation of assessment tools, as well as we're hoping to start to beginning to develop tools that are specifically for deaf individuals. We're involved with training. We invite clinicians to come. We invite people to come from the general community. We host interpreter training workshops every 2 years where interpreters right across Canada come to King's, spend 3 days with us, and we teach them about mental health and what it's like to be an interpreter and what skills are required for that kind of work. We offer general workshops. We offer conferences. The conference that we're hosting this year, the beginning of June, is about deaf children, and we're celebrating and exploring the triumphs and the struggles that they experience. This will be open to teachers, to counselors, to parents, to the general community. So if you're interested, look at our website and please join us. And we're hoping and trying to become a think tank, both nationally and internationally, where we can begin to share information. In some ways, the world has become very small, and I'm fortunate to be invited to go to places like Singapore and Istanbul and Norway and give talks, and I learn at these talks that often we're experiencing many of the same barriers and the same issues, and we're seeing the same things. And we need to get all that data together. We need to collate that data in a rigorous way, in a systematic way, and come up with some practical hands-on strategies that we can be using in our work. So we hope to continue that at CDEAF with that kind of information sharing. I'm keeping an eye on the time, and I know my time is just about done. Now, this is a quote that Helen Keller said, and it really resonates with me. And for a long time, for years, when I gave talks, I always started my talks off with this quote. But today I'm ending it with it. And the quote that Helen Keller, who herself was a blind and a deaf woman, said, "Blindness cuts one off from things, and deafness cuts one off from people." And I would agree. I would agree. But I would like to end with the thought for you people that although I agree with that quote, what I also agree with over the years I've been doing this and my own personal experiences is that awareness makes a difference. Awareness makes a difference. Awareness is a road to an acceptance and is a road to a change. So I urge you and I encourage you to become aware of the differences that are all around us and then change what we can. Change what we can to make our world a more accessible, a more right kind of place in which to live. Now, I'm thinking back to how I started the talk, and I suspect it's probably time for us all to use the bathroom. So I thank you for your attention this morning, and I think we'll have a short break, do we, Bob? And then we'll come back for questions. Thank you so very much for your attention today.